Hello and welcome again to the continuation of the 5th Pancreas Cancer Academy organized by the Central European Cooperative Oncology Group. I want to thank the faculty which participates in this 5th Pancreas Cancer Academy. I want to thank Xavier for supporting it and thank Gerald Prager for organizing the faculty and coordinating the news that are being brought to you. I wish you very interesting hours with the continuation of the Pancreas Cancer Academy, and I do hope that we will see each other in person in the very near future to celebrate the 6th Pancreas Cancer Academy. Thank you very much and all the best.
Hello, my name is Gerald Prager. I'm a medical oncologist specialized on GI cancer. By treating patients with pancreatic cancer, we have to consider that we need a multidisciplinary approach. It's not just like only to give chemotherapy, radiotherapy, or sending patient to the surgery department. It is a multidisciplinary approach where we have to consider also dietitian approaches, supportive approaches, pain management, and so on. And so I'm very happy that we have at this symposium a special focus on frailty and malnutrition and their impacts on the outcome of patients with pancreatic cancer. We have dedicated experts in this field. I'm happy first to announce Andrea Davis. She's a senior oncology dietitian at the Cork University Hospital in Cork, Ireland. And afterwards, we will have the possibility to discuss this topic with Dominiek de Jonckheere from Belgium and Whelan from United Kingdom. So the stage is yours, Andrea. I'm very happy that you have time to give us insight in your expertise in the field of frailty and malnutrition and their impact on the outcome of pancreatic cancer patients.
My name's Andrea Davis and I'm an oncology dietitian at Cork University Hospital based in Ireland. And today I've been invited to speak on the topic of frailty versus malnutrition, the impact on outcome. And I'd like to thank the Pancreas Cancer Academy very much for inviting me to speak today. So firstly, I just wanted to mention that I have no commercial disclosure. Okay, so the contents of the presentation today are, I'm going to speak separately on frailty and malnutrition. So firstly, I'm going to speak about frailty, and I'm going to discuss it under the following headings. So what is the definition? What is the prevalence of frailty? How do we assess for it? And what is the impact of this on outcomes in patients? So frailty is defined as a clinical state in which there's an increase in an individual's vulnerability for developing an increased dependency and/or mortality when exposed to a stressor. And that's from Morley et al. In 2013. So it's a multidimensional geriatric syndrome that's characterized by this cumulative decline in multiple body systems or functions. And it has negative consequences to physical, cognitive, and social dimensions. So this figure here, I thought, just shows quite nicely how frailty can develop. So this shows really the cascade of functional decline in older adults from independence on the left-hand side through to frailty and ultimately disability if the patient doesn't have any intervention. So you can see here that, you know, if someone is quite robust, if they're exposed to a stressor and multiple times, then without any intervention, that patient can develop frailty as time goes on, to the point where they actually become disabled and they are fully dependent on others for their care. So there is an ongoing debate regarding what factors we should be considering to assess frailty, where often frailty is just associated with someone aging. But actually, we know that there's multiple other factors that have been shown to contribute more than age to a patient's physiological reserve. So for example, there are other comorbidities such as cardiac health, diabetes, or neurological deficits. They can contribute more than age to someone's physiological reserve and increasing the risk of frailty. So frailty is often manifested as decreased mobility, having decreased muscle strength, lower energy levels, lower activity levels, and weight loss. And that's according to Rockwood et al. In 2005. What about the prevalence of frailty? How common is it? Well, a study by Vermeeren et al. In 2016 showed that actually frailty is prevalent in all countries, so internationally it's a huge problem. And in the general population, around 10 to 15% of people over the age of 65 years of age are frail. And this increases then with a higher age. So the prevalence is about 25 to 50% in patients who are over 85 years of age. But looking specifically at patients with pancreatic cancer, a study by Nyo Huang et al. In 2019 showed that over 25% of patients with newly diagnosed pancreatic ductal adenocarcinoma were frail, and this was independent of their age. So it didn't matter what age they were, because of their disease. Actually, there was quite a high prevalence of frailty in that patient group. So how do we assess for frailty? Well, many attempts have been made to define and quantify frailty, and I've outlined three of the main sort of assessment methods below. And the reason I'm discussing this is because different studies, when we look at the evidence for frailty and the impact on outcomes, different studies will use different assessment methods for frailty. So the first assessment method is something called the Charlson Comorbidity Index. And this accounts for a patient's age, but mainly focuses on their comorbidities, so either acute or chronic conditions, such as a previous heart attack, dementia, diabetes, cancer, liver disease, and HIV or AIDS. So that assessment method is mainly focused on a patient's comorbidity. The second assessment scale is Fried's Frailty Index, and this more focuses on a patient's functional status. So it includes self-reported unintentional weight loss, exhaustion, slow gait speed, and grip strength. So rather than focusing on comorbidities, this is where a patient reports themselves their functional status, covering those different topics. And the third assessment method is something called the Modified Frailty Index. And this assesses 11 different variables, including the presence of pre-existing chronic medical conditions, impaired sensorium, previous acute events such as a stroke or a heart attack, and previous invasive interventions. So the main question really is, does frailty impact on the clinical outcomes of a patient with cancer, and more specifically with pancreatic cancer? And we're going to look at the evidence for this later, but the answer is absolutely yes, it does. So a study by Diaz-Santos et al. In 2015 looked at patients following resection for pancreatic ductal adenocarcinoma, and they looked at 497 patients in total. They screened for frailty using the age-adjusted Charlson Comorbidity Index, and what they found was if a patient had a score of over 4, this increased the odds of post-operative complications by 52%. It also doubled the odds of a length of stay for over 10 days, and it increased the odds of discharge to a rehabilitation facility by 6-fold. And if they had a higher score again of over 6, this increased 3-fold the odds of death within the first year. So this clearly shows, the more frail a patient is, then the higher their risk of these different outcomes and negative outcomes. Another study by Augustin et al. In 2016, which is a retrospective review, looked at over 13,000 patients who underwent a pancreaduodenectomy or a distal pancreatectomy. And they found that each 1-point increase in the modified frailty index score independently predicted complications. So again, the more frail the patient was before their surgery, the higher the risk that they had complications afterwards. A study by Constantinos et al. In 2017 looked at 1,038 patients undergoing a distal pancreatectomy, and they classified patients into either being non-frail, mildly frail, or severely frail. And again, they used the modified frailty index to assess for frailty. And what they found was there was worsening frailty correlated with an increase in complications. So the more frail a patient was, the higher their risk of complications. So you can see there in the severely frail group, 20% of them experienced complications, compared to those who weren't frail, who only 2.5% of them had complications. So that's a huge difference. Another study by Mogul et al. In 2017 looked at patients who underwent a pancreaduodenectomy, and in total there was 9,986 patients in this study. And the mean age was 64 years of age, and 48.8% of patients were female. And again, they used the modified frailty index to assess for frailty. And what they found was 6.4% of patients had a high modified frailty index, so they were frail. And an increasing modified frailty index was associated with a higher prevalence of postoperative morbidity and 30 days mortality, and they were clinically significant results. So on the graph on the right-hand side, you can see that along the x-axis, it shows the frailty index. So the further along the x-axis, the more frail the patient is. And then along the y-axis, you can see we're talking about the percentage of patients. And the blue line on the top refers to any complication that patients could experience. The yellow line is major complications, and the green line is mortality. And you can see that the higher the patient's frailty index, so the more frail that they were, the higher the risk of any complications, and the higher the incidence of mortality as well. So they had negative outcomes from being frail. And I referred to this study earlier, but Niu Huang et al. In 2019 looked at patients who were diagnosed with pancreatic ductal adenocarcinoma. There was 142 patients in total with a median age of 65 years. And they used Fried's frailty index to screen for frailty. And what they found was over 55% of their patients had sarcopenia, which is low muscle quantity and quality. Over 25% had frailty, and actually the incidence was probably higher than that because they only included patients who could travel to the hospital in the study. So it was likely actually that a higher percentage than that had frailty. And frailty was associated with an increasing comorbidities and worse performance status. And it was also significantly associated with death during the follow-up period. And this included patients who were on curative treatment and palliative treatment. And the graph on the right, you can see that in the dotted black line refers to those patients who were frail, and the continuous black line refers to the patients who were not frail. And you can see that I've just circled in red there the time in months for survival for the patients, and you can see that the patients who were frail had a much shorter survival of 500 months compared to those who were not frail, who had a survival of 600 months. And that difference in survival is a total of 100 months, or 8.3 years, just from being frail versus not being frail. So just to summarize, really, the impact of frailty on outcomes. So frailty has been associated with a higher risk of functional decline, increased post-operative complications, an increased length of stay in hospital, and worse survival overall. Then moving on to malnutrition next. So malnutrition is defined as a state of nutrition where a deficiency or imbalance of energy, protein, and other nutrients causes a measurable adverse effect on tissue or body form, body function, and clinical outcome. And the criteria that we use to identify malnutrition in someone is, firstly, their body mass index. So if they have a BMI of less than 18.5, that classifies them as being malnourished. If they have unintentional weight loss of over 10% in the last 3 to 6 months, or if they have a BMI of less than 20 with a weight loss of over 5% in the last 3 to 6 months, we would classify them as malnourished. So there's many different reasons why a patient can become malnourished if they have cancer. And on the top left-hand corner, I've just put in that image because depending on the location of the tumour, this shows a tumour in a patient's esophagus. So if someone has a tumour anywhere along their gastrointestinal tract, from their head or neck area down through their esophagus, their stomach, their bowel, a tumour anywhere along that gastrointestinal tract can cause an obstruction. And that in itself can make eating and drinking very difficult, increasing the risk of malnutrition. On the top right-hand side, this shows how actually some of the treatments for cancer can also increase the risk for malnutrition. So for example, in surgery, this is where a patient has had an operation to remove the stomach. So if they had stomach cancer, you can see here that the small bowel has been pulled up after the stomach has been removed and joined to the esophagus. So if that patient is eating and drinking, they no longer have the stomach to use as a pouch for their food. So they're going to feel fuller quicker than normal. And also their food is traveling, differently through their system because of the surgery and how everything has been rejigged together. So this will affect their absorption and their digestion, increasing the risk of malnutrition if not managed correctly. And on the bottom right-hand side, this is showing a patient who's had a Whipple's procedure or pancreatic procedure. So again, some of the pancreas has been removed, which is very important for someone's digestion. And you can see that the bottom of the stomach has been rejoined onto the small bowel lower down. So food is now moving from the stomach lower down into the small bowel, sort of bypassing where a lot of the digestion and absorption would normally happen at the top of the small bowel or in the duodenum. So that will, again, impact on a patient's ability to absorb and digest their food, increasing the risk of malnutrition. And then thinking about other treatments that we use in cancer patients. So for example, if patients have radiotherapy, particularly to the head and neck area or the esophagus, or if we give patients chemotherapy, any sort of cytotoxic drugs or immunotherapy, these treatments themselves can also cause side effects, increasing the risk of malnutrition and making eating and drinking more difficult. So for example, if they have mucositis or pain on swallowing, nausea, vomiting, diarrhea, any of those side effects, taste changes, they will all be extra barriers to eating and drinking well, increasing the risk of malnutrition. But it's not just as simple in cancer patients as saying they're malnourished, because we know that often there's something else going on, and this is what we call cancer cachexia. And this is a multifactorial syndrome that's defined by this ongoing loss of skeletal muscle mass, either with or without the loss of fat mass, that can be partially but not entirely reversed by conventional nutrition support. So this is driven by a combination of reduced food intake for the reasons we already discussed, either because of the location of the tumour or the treatments that we've given them. But also cancer patients have these metabolic derangements going on as well, where they have an elevated resting metabolic rate. They can experience insulin resistance, lipolysis, so they have this breakdown of fat going on, proteolysis, where their body's breaking down protein. And this is all provoked by this underlying systemic inflammation that's going on in their body, caused by these catabolic factors. So this slide just shows quite nicely how tumor and cancerous tumors can contribute to wasting and this weight loss and sort of malnutrition. So this is showing really how a tumor can release these catabolic factors and pro-inflammatory mediators, these different interleukins. And what these factors do is they can impact on a person's central nervous system, affecting their appetite, which can result in anorexia and reduced food intake, and result in fatigue as well. But also these different catabolic factors can act on different organs in the body, such as the skeletal and cardiac muscle and the fat tissue. And what happens is this increases sort of the rate of muscle breakdown, this proteolysis and lipolysis, where you have this excess sort of fat breakdown. And altogether then, this results in deconditioning and patients becoming very malnourished. So cachexia can progress as time goes on and as the cancer progresses. So someone can have what we call pre-cachexia, which is defined as a weight loss of less than 5%, but they might be experiencing anorexia and this metabolic change. And then they can go on to develop cachexia, where they have a higher rate of weight loss over 5%. They often experience some level of sarcopenia at this point, where they have this muscle loss going on and low muscle quality. They are often experiencing systemic inflammation at this point and reduced food intake. And then if this continues, they can end up having advanced cachexia, where at this point, really, they have depletion of fat, they have severe muscle wasting, they're immunocompromised, and the cancer really at this point is not responding to treatment, and their prognosis is very poor. And it's also worth just mentioning sarcopenia, because this is a huge problem in cancer patients as well that impacts on outcomes. And this is defined as a muscle disease that may be either acute or chronic. And it's defined by low levels of muscle strength, muscle quantity and quality, and physical performance. And many factors can cause sarcopenia, including malnutrition and aging, which can contribute then themselves to frailty and can worsen frailty. So here you can see aging can contribute to muscle loss. So that the older someone is, the increasing sort of likelihood that they're losing muscle. Disease, so having cancer itself can increase the risk of sarcopenia, inactivity, and malnutrition. So how prevalent is malnutrition? Well, 20%, over 70% prevalence is outlined in worldwide studies. And this level of prevalence varies depending on a patient's age, their cancer type, and stage of disease. And studies dating back over the last 35 years have reported moderate to severe weight loss in 30 to 70% of cancer patients. And specifically in pancreatic cancer, around 80 to 85% of patients are thought to be malnourished. 1 in 3 pancreatic cancer patients have lost over 10% of body weight already at diagnosis. And pancreatic cancer patients also lose muscle mass at a much higher rate than healthy people. So at a rate of 3.1% in 100 days, compared to healthy adults who lose muscle at a rate of 1 to 1.4% over a whole year. So that's a huge difference. They're breaking down muscle at a much higher rate. This review by Ryan et al. In 2019 just summarizes quite nicely, really, the prevalence of weight loss over 5% in a range of different patients with different cancer diagnosis. But I've just circled in red there that actually patients with pancreatic cancer, around 61% of them experience weight loss of over 5%, which is the highest prevalence of most different cancer diagnoses. And then on the bottom, this shows that around 56% of patients with pancreatic cancer have sarcopenia. And that actually, so patients with pancreatic cancer have a similar muscle level compared to patients who are healthy, who are aged over 80 years. So their muscle quantity and quality is much lower than what it should be. So how do we assess for malnutrition? So just quickly, there's various nutritional screening tools that can be used. One that's most commonly heard about is the Malnutrition Universal Screening Tool, but also subjective global assessment is good in oncology patients. And ideally, patients should be assessed within 24 hours of admission and then weekly thereafter. And this can be adapted for clinic settings. And ideally, 100% of pancreatic cancer patients should be referred to a specialist dietitian for assessment because they're so high risk of malnutrition. But importantly, the question really is, does malnutrition impact on the clinical outcomes of a patient with pancreatic cancer? And again, like frailty, the answer is absolutely yes, it does. So this paper, which looked at the diagnostic criteria for the classification of cancer-associated weight loss by Martin et al. In 2015, shows really that overall, for all cancer types, patients that have the most weight loss, particularly over 15% body weight, and the lowest BMI, had the shortest survival compared to those patients who had no weight loss and a higher BMI. So you can see the difference in survival is for those that are most malnourished, they have a median survival of only 4.3 months compared to those who are much better nourished, who have a median survival of just under 21 months. And this figure here just shows, for example, in head and neck cancer patients, the difference in survival for those who are grade 0, which means that they have the least amount of weight loss or no weight loss and a higher BMI, compared to those who are in grade 4 at the bottom. That group is the group that has the highest amount of weight loss and the lower BMI, and you can see they have a much shorter survival. This paper by Wagnalthog et al. In 2017, which was looking at the applicability of a weight loss grading system in cancer cachexia, looked at over 1,400 patients with incurable cancer across mixed sites, and this is an international study. And again, they showed that survival worsened with increasing weight loss, where again, you can see patients in the grade 0 group, which meant they had no weight loss and a higher BMI, had a much higher survival of a median of 13.5 months compared to those who were in grade 4 group, who had the most weight loss and a lower BMI. They had a much lower survival of 4 months. And this was adjusted for age, sex, cancer site, and stage. So specifically looking at outcomes in pancreatic cancer patients, a study by Andrea et al. In 1998, which was a prospective study, compared outcomes of patients with or without weight loss. And these patients were treated for locally advanced or metastatic tumours of the GI tract, including the pancreas. And they found that patients with weight loss developed more frequent and severe dose-limiting toxicities, received 1 month or 18% less treatment. They had a shorter survival and decreased response, quality of life, and performance status. So had much more negative outcomes because they were malnourished. This study by Szerziga et al. In 2007, which was a single institution study of 132 patients undergoing distal pancreatectomy for pancreatic pathology, of which 76 patients had cancer. They used a screening tool for malnutrition, which was Nutrition Risk Index. And they found that a score of less than 100, which indicated that they had a mild risk of malnutrition or more, was an independent risk factor for developing a post-operative pancreatic fistula. So those who are malnourished were more likely to have this post-operative pancreatic fistula. And a Japanese study by Shinkawa et al. In 2013 found that a nutrition risk index score of less than 97.5, which meant they were at medium risk of malnutrition or more, that this was an independent risk factor for developing a surgical site infection after a Whipple's procedure. A study by Latour et al. In 2013, which included 143 pancreatic cancer patients in Italy who underwent pancreatic surgery, of whom 88% of patients were at medium to high risk of malnutrition. They found that those patients who were at high risk of malnutrition had a 4-fold longer post-operative hospitalization period. They had a higher morbidity rate of 53%, and they had an increased incidence of surgical site infections. And then a study called the IMPACT study by Bazil et al. In 2019, which was a retrospective observational study on advanced pancreatic cancer patients who were on chemotherapy treatment, which included 94 patients, and again was based in Italy. 48% of patients were less than 70 and 50% of patients had metastatic disease. And what they found was 21% of patients experienced an early loss of skeletal muscle mass over 10% after 3 months. And this was significantly associated with worse survival and progression-free survival. So on the graph on the right-hand side, you can see that the blue line on top indicates the group of patients who had a loss of skeletal muscle mass of less than 10%. And the red line is the group that had over 10% muscle mass. And you can see that the difference in survival was a median of just under 13 months for those who had less muscle loss, compared to less than 9 months for those who had a higher amount of muscle loss. So there was significantly worse survival in the group that had more muscle loss. A study by Whelan et al. In 2015 showed that 55% of pancreatic cancer patients have low skeletal muscle density. And this is related to higher systemic inflammatory response, this metabolic dysregulation that we spoke about earlier, post-surgical complications, and was related to a poorer prognosis. So to summarize, pancreatic cancer is a major physiological stressor. So the concept of frailty in this group of patients is particularly important. Their body is undergoing, real stress. So we really do need to assess for frailty in this group of patients. Frailty, malnutrition, cancer cachexia, and sarcopenia are all prevalent amongst pancreatic cancer patients, and this gives worse outcomes and poorer survival. So all pancreatic cancer patients should have regular assessments to identify these conditions early, and then be managed by a multidisciplinary team to try and prevent them from, becoming more frail and becoming more malnourished, and to try and improve their overall clinical outcomes. Thank you very much.
Yeah, thank you very much for your interesting presentation, Andrea Davis. It was very informative for us. You were presenting a very comprehensive set of studies showing the importance of assessment of frailty, cachexia, sarcopenia, and weight loss. So my question, of course, we would like to discuss together with Dominiek de Jonckheere from Belgium and Whelan from United Kingdom, would be what is the consequence of it? Do you in your centers regularly assess frailty in your patients suffering from pancreatic cancer? Is this something which is implemented in your daily clinical practice in your centers? May I first ask you, Andrea?
Yeah. So in the hospital that I've just moved to, actually, they've just introduced a new, it's called the GEMS service, and they're called the Geriatric Emergency Medical Service. And they've actually just recently started earlier this year. And they're more around trying to pick up elderly patients in the emergency department. So when they come into the hospital in the first place, trying to pick up any patients who are at risk of frailty there and then to try and, get them referred to the appropriate specialities for that early sort of intervention within the multidisciplinary team. So in the centre I'm in at the moment, that's how they're trying to pick up a lot of patients. But previously in the last hospital I was in, we weren't always regularly assessing for frailty. It's probably something really that the clinical nurse specialists are more likely to do as part of their sort of overall assessment of the patient, meeting them on diagnosis. But I think it's not something that always happens. I don't know how others feel like it's working in their centres at the moment.
Okay. Dominiek, Phil?
I'm a clinical nurse specialist in pancreatic cancer who works in a surgical unit in Liverpool in the United Kingdom. I meet patients at diagnosis and act as their key worker from diagnosis to surgery and then hopefully to adjuvant chemotherapy. And from day one of meeting someone, we focus on prehabilitation. So hopefully making sure someone is fit enough for surgery by using a multidisciplinary approach with excellent dietitians like Andrea, who are so important in a patient's journey, but often get overlooked in the field of pancreatic cancer, which is a personal bugbear of mine. So we focus on prehabilitation, we focus on physiotherapy, we focus on pancreatic enzyme replacement therapy. What we want to do is get someone into hospital quickly, through surgery, out of hospital quickly, but so they are fit enough to have adjuvant chemotherapy. And over 90% of our patients who go for resection in Liverpool go on to have adjuvant chemotherapy. And I think what we do quite well is linking with other specialities. We start PERT very early in a patient's journey. We have a very thorough preoperative assessment. We often consider very early preoperative iron infusions. We link in with the geriatric services about particularly elderly patients who maybe have a degree of other comorbidities or some polypharmacy issues, so they feel supported in their journey. What we also do is try and link a patient with an ex-patient who's been through pancreatic cancer surgery for some peer support. And we think that's quite important because they can share their lived experience. I think the main thing is working as a team. A surgeon is a great person, an oncologist is a great person, a dietitian is good, a nurse is good. If we all work together and assess a patient better, we can hopefully get them through surgery into chemotherapy. But I also think principles of prehabilitation should be focused very much on neoadjuvant therapy and palliative chemotherapy, because those patients, in theory, need the expert MDT support just as much as the surgical patient, and obviously there's more of them.
But Phil, do you know, for patients who are not undergo surgery in your oncology, medical oncology department, do they also assess for frailty? Do you know that?
So patients are, so for non-resectable patients, patients have access to a hepatobiliary dietitian. They will have access to a clinical nurse specialist. They will have access to a patient support network, and they have access to the geriatrician team who link with our local oncology team. That's actually only been a new process for probably the past 2 years, and unfortunately COVID has affected things a little bit. And I think having the geriatricians on board as part of the MDT is a hugely important thing, and particularly moving forward into the future as we have an ageing population.
So it sounds like in Liverpool, an utopia became already true, right? So it's really working very, very good. But can you give us insights in your center in Belgium, Dominiek? Do you also assess for frailty in Belgium, in your center?
In Belgium, yes. It's also the meaning. I work at people who are already operated, so to go to chemotherapy. And we also try, a few years ago, we had the operation in different hospitals, but recently we do it regional. So we have one center who is doing every operation of pancreas. And it's a team that is really experted in all kinds of complication problems that comes with pancreas surgery, and we see a lot of advantages. But despite all the efforts of rehabilitation, we give nutrition advice and things like that. I see a lot of people that coming with me who has to start with chemotherapy that are very vulnerable. They are weak, malnutrition. So despite every action we do, sometimes it still stays difficult to start chemotherapy in our time frame that we are putting. So we try and do a lot of things systematically. Also, people who are elderly and GCA, comprehensive geriatric assessment, to see if it's possible, if it's possible to get that treatment, not only surgery but also chemotherapy. And sometimes we think it's possible, and then it's not always very black white. So sometimes you try it works, and other things you try it and it's not working. So it stays very difficult, and you can't put every person at the same row like that.
Okay, Andrea, I have a question. You have shown us very important studies with high numbers of patients, proving that, for instance, sarcopenia has an effect on the outcome. My question would be, are there any interventional studies that you take actions to prevent sarcopenia, and this is then affecting the outcome as well? Are there any interventional studies you could cite or you could mention?
So when I was looking at the research, there wasn't really very many that I came across, and I think that's definitely a big gap in the evidence. The more I was looking around, actually, there is, I don't know if anyone has heard of it, but there is a trial that's currently underway at the moment. It's called the Menace Trial. And this is actually looking at the multimodal intervention for cachexia in advanced cancer patients undergoing chemotherapy specifically. And it's in lung, pancreatic cancer and cholangio cancer patients. And it's more looking at, not just the nutrition support side of things, but also, other sort of modalities to try and treat cachexia as well, such as like an exercise program And they're looking specifically at ibuprofen as well from sort of the anti-inflammatory side of things to see if that can help to improve and sort of manage cachexia. So we're waiting for those results to come out in 2022. They're not here yet. But yeah, we don't really have, much interventional studies or evidence yet on sort of, the best way to treat it. So yeah, we're still sort of waiting for that. But I think in terms of sarcopenia, and weight loss, we know that trying to use oral nutrition support and, minimize that weight loss is really helpful. But in particular, with cachexia, it's very difficult to reverse cachexia once it's gotten quite advanced. You're just trying to really minimize the progression of the cachexia at that point.
Clinical experience, what is the ideal time point to take any actions in patients who are suffering from weight loss? Is it at the very beginning of the diagnosis as a preventive measure, or do you say no if the body mass index is below 18.5 or weight loss more than 10%, or where do you suggest to start any nutritional support?
As early as possible. So ideally, at diagnosis, as soon as that patient comes through our door, we should be assessing them for malnutrition and frailty as well, ideally, and trying to, refer them to an appropriate specialist for intervention at that point. Because like I mentioned earlier, about 80 to 85% of pancreatic cancer patients are malnourished, and 1 in 3 will have already experienced around 10% weight loss at diagnosis. So, and in pancreatic cancer patients, anyway, we know that they can often present quite late. So by the time they actually see us, they're already often experiencing malnutrition, pancreatic enzyme replacement. They'll probably need pancreatic enzyme replacement therapy. The earlier that starts, the better their outcomes are. So the earlier, the better. As soon as they're diagnosed, really, 100% of pancreatic cancer patients should be referred to a dietitian, to be honest, whether they've experienced weight loss or not, because we know they'll probably have this underlying pancreatic enzyme insufficiency going on anyway.
Are you in your center also part of the MDT tumor board? Do you participate in these tumor boards when patients are discussed?
Yeah, so I've just moved to a new role, but in my last role, as part of the pancreatic MDT, we would meet every morning before the clinic, and any new patients, I would automatically assess that patient in clinic when they come to see the doctor. So they would see the consultant first, and then they would see me afterwards. So that was for patients that were being reviewed really for suitability of chemotherapy, and then for the main sort of HPV MDT. The surgical, there's a separate surgical dietitian would always try and attend that to try and pick up any patients. And the CNSs were brilliant as well at, when they were assessing patients with the surgical team, they were very good at referring patients beforehand as well. So we're, like I know Phil mentioned earlier, prehab. So we're still in the process really of trying to set up prehab, and obviously that's a great way to try and pick up these patients earlier, get them referred to the dietitian earlier, get them assessed for frailty earlier. So that's something that, we still need to work on, that will really help to increase the referrals and make sure we're not missing people and catching them as early as possible, really.
Okay. Dominiek, is it the same in your center in Belgium, that you are a member of the MDT and see the patients from the very beginning?
Yeah, it's also in Belgium like that from moment of diagnosis that we see patients, but with the regional working, it's a specialist of that hospital where the operation is going through, like with Phil, who has seen the patients to start that follow-up, to make sure they have the dietitian to work on, exercise if it's possible, but the problem we sometimes see is the time between diagnosis and operation. It's sometimes too short to have big changes so that you can see. Because if you want to do exercises, you need 3-4 weeks. Sometimes, depending on the kind of exercises, you need a few months. But there's no patient who is going to wait that time before operation. Feeding, nutrition, that's something we do almost every time at the moment that you know it, so that's more easy to start, and patients understand that also, because but exercise, that's a little bit difficult, because if you want to have a big results of that program, you need more time, and mostly we don't wait all those weeks before operation. So we more see the advantages of that kinds of programs after the surgery, and the advantage of chemotherapy and while the chemo is running, but not always before operation, because it's too short.
Too short, okay. For IV nutritional support, is there any threshold you would consider to start IV nutritional support?
Sometimes we do it. Sometimes we give tube feeding by stomy. I had patients that who had malnutrition after the operation, and it was not possible with everything we had to correct that. So the patients received TPN, total parenteral feeding, through all the chemo period, because it was the only thing we had to make sure that nutrition was okay. So sometimes we have to use that if nothing else works. So it's sometimes searching. It's not ideal, but yeah, you have to choose sometimes.
Okay, Phil, may I ask you, so especially after surgery, is nutritional support something you see very regularly in pancreatic cancer patients? You have to do that around surgery?
Yeah, of course. Obviously, we have our own pancreatic dietitian who will review our surgical patients on a daily basis. I'll provide an assessment of a patient on a daily basis and update a patient's family. With patients who have got post-operative complications, maybe a leak or a delayed gas, we would on TPN then, but we wouldn't often do that for probably the first 5 to 7 to surgery. We would wait. I think the importance of what Andrea said about starting nutrition assessments very early on is key. In my perspective, every person who is diagnosed with pancreas cancer or suspected pancreas cancer should start on pancreas enzyme replacement therapy straight away. Obviously, we can increase and titrate that after surgery and throughout chemotherapy. But there's still a lot of people who come to a clinic and they maybe have come to a tertiary centre and they've been diagnosed elsewhere a week or so earlier, and unfortunately they're not on pancreas enzyme replacement therapy. And a lot of work in the UK is to try and educate and communicate with centres about saying, please assess by a dietitian, please start PERT, so we can try and get our patient as fit as possible for major treatment.
Okay. What about exocrine enzymes for support, digestive support? Do you prescribe it very regularly? Probably that's yes. After surgery, or all patients, also non-resectable patients?
Well, the current NICE guidelines in the UK says all non-resectable patients should be considered. I think the data about surgery didn't actually suggest that, but in big pancreatic units, every single patient will be prescribed or considered for pancreas enzyme replacement therapy. It's so important. It just makes no sense not doing it.
Okay. I see there is a lot of consistency across countries here. How important nutritional support is for pancreatic cancer patients. So what about frailty? May I come back to frailty assessment, which we discussed at the very beginning? So back to you, Andrea. Is there an index which you would prefer in the clinical practice? You were highlighting 3 different indexes, the Charson Comorbidity Index, the Fried's Frailty Index, and the Modified Frailty Index. Is there one you would prefer for the daily clinical practice outside of clinical studies, which is, let's say, less complex and easy to use?
Yeah, so the ones I was referring to earlier in the presentation were really just to help understand what assessment methods they were using in the studies. But in reality, in clinical practice, they're not most usable ones. So in the the hospital where I am at the moment, I was mentioning sort of the GEMS service that works with the emergency department team. And what they do is they get the emergency department staff to do like a very quick assessment. It's called a VPI sort of score. And that just asks a couple of general questions, around mobility, if someone lives alone, if someone's able to sort of manage independently, with activities of daily living, to just quickly screen for whether someone is at risk of or at risk of frailty or not. And it's just a very easy way to make sure that patients are quickly screened for frailty, to then refer on to the geriatric, the GEMS team for a full comprehensive geriatric frailty screen if needed. So that's one way they sort of found that it's much easier to make sure that patients are actually being screened, because I think the problem is when you're screening for so many different things in a patient, it's easy to overlook frailty if it's quite a long sort of screening tool that you have to do. So they just do a very quick screen with a couple of sort of key questions, and then if they are flagging as at risk of frailty, then they'll refer on to this this MDT for geriatric patients that then are in the ED department as well, and come and assess the patient and do a full comprehensive geriatric screen on them. And that will be done either by a dietitian or a physio or one of the doctors or the nurses, whoever is sort of most relevant to what that patient's issue is. And they find that works quite well so far. So I'm not actually part of the frailty team, but from listening to what they do, that's how it works, and it seems to be working quite well to pick those patients up.
Okay, thank you very much. We are almost at the end of this symposium, but we still have some time for a final comment of everybody of you. May I start with you, Dominiek? Do you want to highlight or summarize on this topic something?
I think it's very important that the treatment is done by a team. Dietitian, clinical specialist, social service also, because a patient who is alone needs more support to take sure that every nutrition advice is followed up also. Also psychology, because the motivation of the patient to follow things, to take medication is also very important. And then it's three things that are going together, in my opinion. It's nutrition, it's education, and also mobilization. So exercise, and then take sure and make sure that exercise is keep on moving. It's not enough to do it 3 months and then stop, because the recoverance of operation to the pancreas, also chemo, takes months. So 2 months exercise and nutrition, it's not enough to recover enough. So it has to take a long time enough, and it's necessary to have a good follow-up by people that have a lot of experience.
Thank you very much. Phil, any final comments or conclusions?
Just a very quick. I think I was at a conference at the COCG a few years ago, and someone put a slide up, and it was about rehabilitation, and it just was very basic and said, "Fitter patients will do better with treatment." Big exclamation mark. And there's loads of studies that Andrew's talked about, which are brilliant, but it's kind of common sense, isn't it? If we get a patient and we can help them be fitter through an MDT approach and through learning off each other, then we hopefully will have better outcomes for that patient. But I think what we have to do is, as clinicians, is make sure our patients have access to all the relevant members of the MDT, and the MDT is funded correctly, and also we include patients when we're making decisions. And that's why we do have patient representatives who sit within our unit in Liverpool who give us advice about future management and future studies and future publications and future, hopefully, progress within the unit. So very much need to work as part of a team and include patients.
Thank you so much, Phil. Andrea, any final comment? Yes.
Yeah, I just completely agree with what Dominiek and Phil have just said. I think from my experience as well, particularly from a dietetic aspect, it's that early intervention for us, seeing patients at diagnosis and working with them from the the very starting point is what will make the biggest difference in terms of the malnutrition. And then that has a knock-on effect on frailty as well. So just that early sort of referral, early intervention, and having that MDT around you to support you. And I think, like Phil said as well, just, training and advising other sort of staff members and other people in different centres that might not have access to specialist dietitians or specialist physios, etc. But being a point of call for them to share your expertise and support them as well, as much as possible. So for every pancreatic cancer patient, you're trying to increase their access to those MDT members as much as possible, really.
Really, yeah. So I also can conclude that pancreatic cancer is such a complex disease which really requests a multidisciplinary team with all the support of nutritionists, of nurse support, of all the different kind of experts to support our patients, and then hopefully they do better with a systemic treatment or surgery with the aim of a better outcome. And in this respect, I want to give my thoughts now to Francesca Bess. She was a patient in one of our previous symposium of the Pancreatic Cancer Academy, of the 5th Pancreatic Cancer Academy. She previously gave us an insight how it is important to support patients from the patient advocacy groups. And she was reporting her support within these difficult circumstances of the pandemic. And she unfortunately deceased at the end of April from pancreatic cancer. I was very impressed by her report, how she experienced her disease of pancreatic cancer, and she gave back so much to other patients with her patient group, and so I want to give my thoughts to her. So thank you very much, all of you today, for this very interesting, fruitful discussion. It was really an excellent presentation, Andrea. I learned a lot from you, and thank you very much to everybody, and have a nice day. And if there are any questions, I would be happy to come back to you. Thank you.
Thank you very much.
Thank you.
Thanks.